insulin and we had mixed insulin. And that time insulin use, there were no disposable syringes. They were very expensive. There was a glass syringe and which had to be boiled and given that way. So now insulins also, you will see there are a variety of insulins which have come, which are sort of called designer insulins, so that they match with the normal physiological insulin secretion by the body.
Could you please throw some light on designer insulin? What do you mean by that?
See, normally, again, when I talk about designer insulin or whatever, the newer treatment, whenever treatment gets evolved, these treatments are evolved in a way so that it matches your normal healthy body's physiology. So when you look at the normal healthy body's insulin secretion, there is a basal insulin secretion which goes on for 24 hours. Throughout the 24 hours, your beta cells produce a basal level of insulin.
Definitely.
And whenever you eat,
it rises.
It peaks and then comes down over a period of time again to that baseline. But when you give insulin from outside, two things. It has to maintain that basal level, and you have to give insulin, short-acting insulins, which we call, which would have the same peak like what is normally produced when you eat. So these newer designer insulins are again divided into two. They are basal insulins, which give you a basal insulin coverage for 24 hours. These are called peakless insulins. And the newer ultra short-acting insulin analogs, as we call them. So when you take them, there is a spike in insulin levels, and over a period of time it comes down. And the time frame during this happens is being done so as to match the normal physiological peaks. So these are the designer insulins which have come. Regarding the oral drugs also, there are many oral drugs which have come now. Newer, what we call as newer sulfonylureas. There are drugs,
the GLP-1 and
GLP-1 receptor agonists. There are drugs like SGLT2 inhibitors. So these drugs, like for example, SGLT2 inhibitors are the newer drugs. The way they work is they excrete excess of glucose through your urine. So that they excrete the glucose through your urine. But it has also been seen that apart from glucose lowering or blood sugar lowering effect of these drugs have other benefits in terms of cardiac benefits they have shown, in terms of renal benefits they have shown. Similarly, as we are talking about GLP-1 receptor agonists, these are the newer drugs which have come. These are GLP-1 drugs in terms of injectable, like oral also has come. Oral semaglutide is there, and injectable drugs, as you said, Ozempic is the one. It is the injectable form of semaglutide. Only thing is in India, it's not yet available, but oral is available in our country. And these drugs, even there are other drugs which work on the same axis as we call as the incretin axis, which are called DPP-4 inhibitors, the gliptins. These are the ones which are. But GLP-1 receptor agonists are the ones, again, like the SGLT2 drugs, as I mentioned to you. These GLP-1 receptor agonists have been very clearly shown to have cardiac benefits. So nowadays, when you look at the guidelines for treatment, the treatment guidelines do mention that you look at the patient, whether the patient has cardiac risks or has an established cardiovascular problem. And if the patient has an established cardiovascular problem or cardiovascular risk factors, you should consider GLP-1 receptor agonists.
So a lot of people are using it for weight loss also.
Yes. It is available. It is approved for weight loss also, specifically the injectable one, Ozempic. Even the oral semaglutide has been shown to cause weight loss, and it is being used for weight loss. It does. But let me tell you one thing, I mean, it is a drug which helps weight loss. But it is not a drug which people feel that I won't do anything, let the drug do everything.
It will, exactly.
You have to have that lifestyle modification.
Definitely.
You have to have proper diet, you have to have a change in lifestyle, proper exercise, and then these drugs would help. Second thing, the amount of weight loss, that is also a thing. There are some patients who have a good significant weight loss, but on an average the weight loss is somewhere between 5 to 10% of the baseline weight. So depending on the baseline weight, it's about 5 to 10%. Some patients do have more than that, and significantly more than that.
Depends on the patient profile.
Depends on, but on an average it is 5 to 10%. But let me tell you one thing, this even 10% weight loss is metabolically beneficial. So 10%, if it's been shown that even if there is a 10% weight loss, it has a benefit in terms of reducing the risk factors or complications of diabetes. So that is a significant weight loss that is achieved.
So sir, is there any particular division when you